So I'm almost always, when I speak in front of an audience like yours, I am humbled by the enormous reflection that comes from living with EB and from being able to gather around this condition a number of individuals that are motivated for life to make it livable and ultimately cure it. So I always start from thinking, maybe you should too pause a little bit and reflect on what you are a part of, because this is unique, this is rare. I've been in medicine for several decades. Related to Dr. Stern's talk, I started as a surgeon, putting bones together. And I study not just medicine, but I have a big laboratory. I study stem cells, which are the masters of all cells. I study the blueprint of these cells, the DNA or the genome, and how we can change it. And then I obviously have a busy clinical life with bone marrow transplantation as the field that I have chosen now. And I see that these hurdles occur in medicine all the time. And it really is not a given that a certain hurdle, such as difficult to treat disease, surgical complication, infection, it's not a given that it's actually going to be solved. Most of these hurdles go unnoticed. You can only look at number of neurologic diseases, degenerative diseases that have no attention at all. So having a body like DebRA, like this patient conference, even though Brett's going to change the name, is unique, not only in the potential it gathers, the potential of people like yourself in this room, the potential of people that are feeling and thinking like you do, but it also brings the optimism that this can be overcome, and some of the terrible parts of skin blistering and tissue healing can be made much, much better. So I'm grateful to be a part of this, because I've seen as rare diseases, or maybe less rare than EB, that have none of this support and have none of this momentum, and subsequently they will not see the accomplishments and the changes that, in my opinion, will happen for EB and have started already. You're very kind, thank you. So bone marrow transplantation, which is my clinical job, is simple. You take bone marrow from one individual and you keep it in a plastic bag, you bring it upstairs to the clinical floor, and you infuse it in the vein of a child or an adult with a certain condition. The fact that it even works is unbelievable. If you look back half a century means that's when my parents were young. Everybody who had leukemia, everybody who had lymphoma, everybody who had any kind of these cancers was dead. Everybody was dying from the moment they were given the diagnosis from their doctor. And you have to compare it, and it's relevant to EB. You compare it today to a situation that 95% of children with leukemia that I treat will be totally cured of their disease, and about 50 or 60% of adults will. And the change, the delta, has been all in research. It all came, anything that I know that worked in medicine in last 150 years, because everything before the 19th century is probably a placebo effect. Everything that I know started in the lab, started in research lab, and then transitioned to clinic. So the way bone marrow transplant came about as a tool to treat malignant disease was a result of series of investigations in the United Kingdom in the group of Peter Medawar, who was trying to figure out how to, again, relevant for EB, how to fix burns, because he saw the pilots coming from, during the Battle of Britain, coming from the continent, and the few that were fortunate enough to survive a direct hit came back and were badly burned. So he tried to skin graft on these individuals and failed many, many times, which is another theme, I think, that was very pertinent to me and everything I know about medicine, which is that failure is a part of success. You cannot possibly design something that's very consequential and successful unless you are able to withstand and accept failure. So he failed in that, but at the same time, he figured out that he can change the skin grafts only in animals that also had exchanged bone marrow. So he, for the first time, was able to show that you can, in fact, change the bone marrow. And at the same time, the group on the other side of Atlantic, Don Thomas and others, have said, well, we have all these unfortunate adults that I mentioned in the beginning that have these leukemias. And these are the cancers of blood. So maybe if we change the bone marrow, maybe we can cure them of their leukemias. And that's how bone marrow transplant came about. So it started as a stem cell therapy. And with the hype and hope that stem cell therapies are surrounded with today, it's probably important to remember that bone marrow transplantation has been a useful, proven stem cell therapy for 3 or 4 decades. And then, as it happens in biomedicine frequently, I think, totally by serendipity, the first time a bone marrow transplant has been ever successful, which was in November of 1968, there was a different group that worked on something totally different and figured out that if you have a cell that is genetically incapable of making a protein, you can think of EB, type 7 collagen, or laminin 332, one of the 3 chains, so on and so forth. If you have a cell like that, in certain instances, and typically the instances where this is a protein, this is an enzyme, if the cell makes that enzyme and secretes it outside, it's possible that it can correct, it can help the cell that genetically cannot do that. And that's called a cross correction. Basically, you mix these cells together in the petri dish and they correct each other. The ones that had the disease, when mixed with the one that did not have the disease, upon mixing them together, don't have the disease anymore. So you have immediately an application of bone marrow transplantation in diseases that are non-malignant, yet equally fatal as any leukemia I know, by providing the bone marrow transplantation for somebody with genetic disease and curing their genetic disease with this. And we've been using this method for children with genetic disease such as enzyme deficiencies since 1980. So a long, long time. So for as many years, 3 decades, give or take, bone marrow transplantation has also been the first gene therapy. Again, a frequently forgotten thing. So we have, in the recent 7 years or so, we have extended that concept that has already been, in the medical knowledge, maybe not as prominently as it should be, to the conditions of the skin, such as epidermolysis bullosa, where it's not the soluble protein, the enzyme, but it is the structural protein of the skin. And that is the novel thing. And that translated into 23 transplants in Minnesota. There is 1 successful in Denver. Dr. Berkner is here. There were 2 done in Colombia with Dr. Cairo and Dr. Cristiano. There are, to my knowledge, there are 2 done in Vietnam, which I don't think were successful. And there's certainly programs around the country and in Europe that we are trying to help to see if they want to join in this effort. So what we have learned is, and this, if you remember one thing from what I say today, this is the one. We have not found a cure of EB. Okay? Not cure. What we have done is, for the very severe forms of junctional epidermolysis bullosa and for the generalized severe recessive dystrophic epidermolysis bullosa, we were able to change in some individuals, about 2/3 of the ones that we have treated, from an acutely lethal or debilitating disease into a chronic one. Every single of the children that I have treated has remaining lesions. It is true that they live lives that are better from the standpoint of pain, quality of life, but they are certainly not cured. And that's why we have chosen the path of rapidly adapting the clinical trials. So we had 3 trials already that we are trying to improve very quickly out of responsibility to individuals with epidermolysis bullosa, adapt it very quickly to what we learn. Because the obvious statement has to be made, which is, at the very beginning, we don't know what's going to happen exactly. And we have changed the way we treat these children and the way we take care of them outside of the transplant, support them through it dramatically between the first ones and the ones that come today. But what we have seen is that we, both in animals, which are indispensable for medical research, and in the children that we have treated, we see that we can see the type 7 collagen throughout the body after bone marrow transplantation. We see clinical responses in many. And most recently, and for me very excitingly, we've been able to show that you can get the same benefits with less toxic chemotherapy that has to be given before you give the bone marrow transplantation. So we can get much less injury to the kidney, to the lung, immune injury from graft versus host disease if you use the recipe that we have put together for the last 5 individuals. And I think that we will be coming back to the platform that I've designed a long time ago, which is not separating things. You know, many of things that we do in medicine and in research is artificially fragmented. We are still looking at the same condition, we are still looking at the same cells, and it is the disbalance in our expertise and, you know, whom we know and where we train that artificially puts the brakes in between. In my opinion, I use everything that helps. So sometimes it's a murine model, sometimes it's a clinical trial, and sometimes it's what I'll be talking in a minute about, which is taking the cells from individual with EB and modeling the disease in the Petri dish so that you can get an insight into the pathology of the disease, how the cell works without type 7 collagen, how does it work with type 7 collagen, and maybe you can shortcut many of these things because these cells can be used as a ex vivo clinical trial. It's sort of a clinical trial that you don't use the people for. So importantly, this is a steep mountain to climb still. We have some evidence that we have been able to change the severe disease into milder one, that there is less pain, that there is better quality of life. We hope that this translates into less risk of squamous cell carcinoma. We hope that this is going to be permanent, you know, as we have seen in children that I treat with enzyme deficiencies or with leukemia and lymphoma. But certainly, many things remain that are entirely unanswered, and I'm under no illusion that unless we continue this path of combination of the incremental improvements with these quantum leaps of innovation, that we will not change that. So what are the ideas that may help? Some of the best ideas I know come from looking, from nature. So in this lawn of azaleas, you know, this part that is darker pink is the one that changed genetically the gene for the pigment, the gene for the color. It's called Mosaicism. This is a boy I've treated some time ago, and on whole his body, he's got the lesions of recessive dystrophic EB, and there is one patch that his mother told me it never blistered. And you know, from very early on, you know, there are different layers of information I get, but the first rule that I have is listen to the mother. The mothers, no, Thank you. And so I do. And so we've taken, because the skin was so very different, we've taken a sample from the skin that was blistered and not blistered, and basically confirmed what others have seen. John McGrath in London was the first one to publish this in recessive dystrophic EB. Marcel Jonkman and his group have found this in junctional epidermolysis bullosa. But we have seen that the nuclei here are blue, and the collagen type 7 is this band in red. So this is the blistered skin that doesn't have it. This is the non-blistered skin that does have it. So within the same individual, you have two populations of cells, one that is able to make the all-important collagen type 7 and the anchoring fibrils, and the separate part of the skin that doesn't. When I take the cells into the petri dish and stain them to see whether they are truly skin cell keratinocytes at the green color with cytokeratin 5, and compare these two cell types, then I see that there's no collagen type 7 here, which would be shown in red, but there are these red parts over here, which tell me that truly these cells are making the collagen type 7. So if I go back to what I said at the beginning, which is that the bone marrow transplantation can serve as both stem cell therapy and a gene therapy, then ideally you would have this natural gene therapy occur. So that means that you would have taken the parts of the body that self-corrected itself, and you don't need gene therapy at all. And then you would use these cells to correct the rest of the body. And that's what we and others, Dr. Cristiano and others, in Europe are working on today. But the challenge is that majority of individuals with EB most likely don't have a revertant clone in their skin. And for those, there has to be a backup. There has to be something to do for them. And gene therapy is the answer. The fact is that you need to, with the current knowledge, we have to use some tools, again, from nature to get these genes into the cell, because our cells have evolved to resist all others' blueprints of life, all others' genomes, like bacteria, viruses. So our cells are very efficient at getting rid of them. So to bypass these bottlenecks, to bypass these hurdles, one has to use something that's smart enough to get the gene of interest, the gene that you want to put in that EB cell, and cross all these boundaries. And it so happens that we are not smart enough to do it on our own, so we use the viruses to do this. So that's the manufactured gene therapy. And there are many flavors of this, and typically these are the viruses that cause cold, like adenovirus, or there are retroviruses that cause some other diseases that lived with humans and other mammals for eons together, and they sort of establish a certain balance. But we can use the toolkit that these viruses develop, that's usually the flanking regions over here and here, to deliver the cargo, which is usually the middle part, which is like type 7 collagen gene, into the cells that we want to correct. And we also, and that's the third theme, which is we should be looking around. And I talked to John Dart this morning and Alex Silver about this. We need to look elsewhere, wherever we can find anything that helps EB. And gene therapy for other disorders is that realm, because we don't have to repeat all the challenges and all the mistakes that have been done before, and we can streamline this for EB and make it safer and more efficient. The advantage we have is that in a condition which is an immune deficiency, there are children that are 10 years old or more after very successful treatment with gene therapy from their own bone marrow cells. So that's where this sort of comes together. You don't need cells from somebody else if you can gene correct your own. I know it's simple, but it's simple. The simplicity is important, because the simpler the medication, the simpler the intervention, typically the safer that is. So we can learn from the successes of that, but also from the challenges of this. And the challenge of the gene addition, which is basically you take a virus, you put it on the cells, the virus makes it into the cell, into the headquarters of the cell, which is the nucleus, where the blueprint of life is, the genome. And then the virus does whatever it wants, which is it inserts itself into the place that is very open, that's nicely regulated, that has a lot of good factors coming to it. And it so happens that these genes are frequently the ones that are associated with growth of the cells. Where it becomes more difficult is that the same genes that in normal life regulate the growth of the cells also, when expressed very highly, can lead to cancer. And that's what happened in a number of these children, that they developed leukemias that were entirely because of use of the viruses. So that's why we and others are looking at the so-called gene editing. And what that means is that you don't paste in a new gene somewhere in that genome, but what you do is you go at that one typo, that one nucleotide in the DNA, and you take out that single one. And I know that Dr. Lane, I don't see him here, and his group is working on this, and there is another, he's there. Oh, he's the short one, yeah. And I think that their group and others will see that this, in fact, is possible. It's almost like a genomic surgery. You go with scissors, with a knife, into that very part that you want to correct, and you provide it with a template that's healthy template. And then again, we are coming back to the same theme again and again. We learn from nature more than we can invent on our own. You use the normal way of how our cells repair themselves to incorporate this new nucleotide, this healthy base, into the laminin 332 genes or in the type 7 collagen, and then you end up with a normal functioning cell. The last part of my comments is going to be spent on what kind of cells you use for this. So it must be obvious now, you cannot just take a gene therapy toolkit and throw it at the patient or at the individual with disease. You have to have some kind of a cell vector, some kind of a cell type where you house this particular treatment modality. And that's been difficult because some of the cells readily take in the genes from the outside, and blood stem cells have been ones that were very easy to transplant into the individuals. We talked about the 4 decades of successful use of bone marrow transplantation, but they are very, very fragile. They are very difficult to what we call transfect, which means that you incorporate the new genes into the cell. And there's a good reason behind it, by the way, because this is the defense mechanism of these cells, because they are so key to normal functioning of blood system and immune system, that if you have a small error in one of these master cells, it can amplify very, very quickly into a cancer. So that the blood cells live different times. The white cells, for example, they live a couple hours. The platelets, they live about 7 days. The red blood cells about 120 days. So you have to make many of these cells all the time, every day, just to stay on the same place. So the fact that these cells are sensitive to introduction of new DNA, new genes, is their safety mechanism to prevent cancer. There's, however, a way around it. The cells that are typically able to grow on a plastic dish, they are typically better at taking up the new cells, new genes, but they are more difficult to introduce into an organism. And the ones that I'm going to be talking a little bit about are called induced pluripotent stem cells. So I've said that the stem cells in general, it's a very fluid term, and we have to be careful what we call stem cell. It's really the master cell that is able to make more of itself and also make more of the cells that can actually do the job. So the job in the blood system, for example, is to fight infection with the white cells, carry around oxygen with the red blood cells, clot the blood with the platelets. That's the function. So hematopoietic or blood stem cell does not do any of this. It's just the bank. It's sort of a master bank for all these cells that can actually do the work. So that's what the stem cells are. The pluripotent means that they can make a lot of different tissues, not just the blood, but others as well. And induced means that they are not taken from the normal part where such stem cells live, which is an embryo, but they are taken from skin, from something that is very, differentiated and very mature and, easy to access. So that's what you can do. About 6 years ago now, Dr. Yamanaka and his group in Japan were able to figure out a puzzle that no grant agency would ever fund. Basically, they showed what was obvious to everybody, which is a theme number 4. That the fact that everybody thinks that, or the field thinks that this is how things should be, does not necessarily mean that that's how they are. So he basically proposed to take cells from the skin and make embryonic stem cells from them using several factors. That's so outside of the thought of the research and scientific community that nobody would ever fund it. But he did it, and then then everything else is history. So what basically we can do, because of what his research initiated, take a skin biopsy, grow the skin cells, keratinocytes or fibroblasts, in a plastic dish, induce between 1 and 4 different genes in them, and then support them with a what we call a feeder layer, which is we give them some other cells, typically murine fibroblasts, that are irradiated so that they don't grow, and they make these colonies that then can be taken into just about any part of the body. So you can have, there are sort of the 3 groups in the body composition, usually the one that covers our surfaces, skin, brain, and nerve system, then the one on the inside, like lungs, stomach, liver, pancreas, and intestine, and then the stuff in the middle, where blood, heart, kidney, muscle, and bone is. So this is the recipe. It's so simple that I would say there are hundreds and hundreds of labs in the world that are doing this. What we wanted to show is, can we adapt this to EB? So I started first with recessive dystrophic EB, and I wanted to show that you can make blood that you can use as a bone marrow transplant from skin. And so you take a skin biopsy, and this is the goal. So we have quite good way of knowing what is a blood cell and what is not. And what we do is we culture these cells in the lab, and then we count the number of these little cultures that's in the graph over here, and compare them to the normal marrow. So the number of the colonies that have been made is about the same. And the red stain over here shows that we were able to correct these cells. So you have a opening now that you may be able to take the skin cells from a child, from an individual, from a subject with EB, gene correct them, and then amplify them through these induced pluripotent stem cells, make a lot of them, inexhaustible supply for the rest of their days. And then you can use them as a bone marrow transplantation that they cannot reject. So there's no immune problems like we see every time with when you use transplantation from somebody else. And then we wanted to repeat this and show in junctional epidermolysis bullosa that we can make cells, more skin cells. So many of the stem cells in the skin are depleted in children with and adults with epidermolysis bullosa because they are called for so much. There's so many signals that say, make more of me, make more of skin, and yet they through this circle of growth, they get eventually depleted. So it's difficult to know where would you take the cells to gene correct in somebody like that. And there was a clinical trial years ago in Italy. Michel De Luca and Fabio Mavilio have done it, and that was the main problem. They couldn't find enough stem cells in the skin to gene correct. So this is the way around it. So we've shown that not only that you can get the skin cells, the keratinocytes, you can also correct them. So again, the green color shows that these are keratinocytes. This red stain shows me that the, in this case, beta-3 chain of the laminin 332 is being expressed outside of these cells, which is very important. That tells me that they are functional. And then this is what a skin would look like, only this skin has been made in immunodeficient mouse. So this is a human skin in an immunodeficient mice that has the layering of a normal skin and expression of this all-important beta-3 chain here in the right location. And this is the same thing for type 7 collagen in recessive dystrophic epidermolysis bullosa, again showing that you can make the skin in the three-dimensional way. And this shows in the junctional, again, that the proteins that are expressed to make the laminin 332 triplet are expressed as these bands over here outside of the cells, which was an important thing for me to know, because you want to make sure that all the possible functionality is there. And then this image shows that the whole laminin 332 triplet is actually being made, these are the red dots, on a skin that for all practical purposes looks like normal skin. So we are going back to the very beginning, which is how are stem cells useful and how they can be useful for individuals with EB. And the answer is a lot. So the skin field, dermatology, has been pioneer in regenerative medicine. A clinician scientist, Howard Green, 30 years ago, has shown what nobody thought was possible, which is to culture the skin cells and expand them in a plastic dish. And he did it by observing tumors in mice. And he realized that they need some factors, some growth factors, that cannot be supplied from the media, from the nutrition fluid that we surround the cells with alone, but they need the other cells. So he was the first one who actually put dermatology in the, squarely in the midst of regenerative medicine. And with bone marrow transplantation, that is the only regenerative medication, if you will, applicable. You still can cover large areas of burnt skin with cultured keratinocytes. So our ambition and our ideas are focused on using all this knowledge, all this past knowledge that I've mentioned, from all fields of medicine and science, and focus them on a task that will benefit individuals with EB. And this is not a long struggle. This map shows number of clinical trials that are in existence now with stem cell therapies around the world. So the red, satisfyingly, that's why I crossed the Atlantic 20 years ago, is in the United States. And then, the green is the least, but still, this is a significant number of clinical trials. Most of them are hematopoietic stem cells, but there are neural mesenchymal stromal cells that you've heard about, adipose and so forth. But it is quite likely that we will be using the technology that I described, gathering the induced pluripotent stem cells for to benefit subjects with epidermolysis bullosa. I'm not saying that we will use them directly. I personally think that there is going to be a second and third generation of what we call reprogramming, and I think that we will never use them as a tool, as a treatment on their own, but they will be very useful as a master bank for cells that can be derived from them. And sometimes they're going to be cells lining the mucosa of the mouth, sometimes they are going to be skin cells, and sometimes they're going to be blood cells. So going back to the very first things I said, the first successes in stem cell therapy were in cancer, in children, and we can take some assurance from having done that we will follow the same path. We still have to figure out many things, including immune interactions, including how exactly we gene correct this. But these are not trivial, they are complex things. But in the big scheme of audience like this one, and group like this one, where you've been able to gather people from the families, the individuals with EB, academicians, people from industry, patient support groups. This is achievable. This is something that can be done. What we need to be very clear about, that we accomplish that all individuals with EB have an access to these things, that we have a good endpoint, good readouts. We again this morning talked about how to put together a system when we know that the readouts are actually reflective of the accomplishments, positive or negative, in a certain clinical trial. The cooperation is almost a given, because any kind of fragmentation, any kind of ego-driven parts are totally secondary and will almost always fail. And the goodwill, there is plenty of that here. So it's a multifunctional enterprise with EB families, DebRA, but other things, things that really require a comprehensive and deep understanding of how the regulatory systems in Europe and in the United States work. How does the clinical application of stem cell and gene therapy work? Integrate the research, because as I said, there's going to be no advance without that. And how to build the molecules that can do this. My recommendation for the future would be change one thing at a time. There are so many clinical trials that failed that I know about because people are, in this sense, too ambitious, that they change three things at the same time, then there is some kind of a result which is uninterpretable. Nobody benefits. The risk stratification is important. The database that DebRA supports and others in this room have worked on is a key, to understanding different subgroups of within EB. And these may not be genetic subgroups. These may be subgroups in response to certain treatments, as we learned in oncology and in other genetic diseases. The therapy needs to become personalized. And the induced pluripotent stem cells is a way to get that quantum of knowledge that one needs to do that. I've been always very grateful for Dr. Elaine's writing and Dr. Berkner's writing on the moral and ethical ramifications of what we do. And it is important to consider these, and I do daily, to triangulate, where we are at in relationship to these questions. I do think that the EB cell gene therapy or stem cell therapy is transitioning from the concept to reality. There are several trials that will confirm that. And the goal, of course, is a concrete, meaningful, clinically meaningful change. That's it. That is the goal. That's not more complicated than that for individuals with EB. All right. I would not be standing here today if I didn't get help from many, many people in the room. I'm deeply grateful for everybody who funded this research, everybody who contributed to it. I am on a totally different level and really on a much deeper scale grateful to all the individuals with EB and the families that I have met, because that is ultimately why I do what I do, and that is ultimately why I'm honored to be here. Thank you.